Welcome back to another video. We're talking about the 4 different types of PCOS today because did you even know there was 4 different types? Probably not, and your diagnosis that you got might actually be incorrect. I know. There's a lot of people walking around here who are not diagnosed, which causes a lot of issues for your future health, but there's also a lot of people who are walking around here who are misdiagnosed, thinking that they have PCOS, but they actually don't. And a quick disclaimer here, this is not medical advice, this is just for educational purposes only. Now, with the 4 different types, it kind of works in like a hierarchy. First, we have insulin resistance PCOS. Next, we have post-pill PCOS. Then we have inflammatory PCOS. And then last but not least, we have adrenal. If you have insulin resistance PCOS, you're going to test your blood results for insulin, your fasting insulin, and it's going to be high. This is the type that about 70% of people who have PCOS actually have. This is the most common type, and you're going to get your classic symptoms of androgen excess. You might have some acne, facial hair, you might have extra weight gain. You also will see your regular cycles, your period might be missing, or your cycles come every like 60 days. If you get that blood test and you do not have insulin resistance, then we're gonna move down the line into that post-pill PCOS. Maybe you just got off the pill and that's causing your PCOS. So basically, when you stop those hormones, your body can have like a rebound effect of androgens, so then this can cause those PCOS symptoms, but generally this is just temporary and it will go away in maybe like 6 months to a year. Generally, that's kind of what we see. Now, you would have had to have regular periods prior to going on the pill. If you had irregular cycles before you went on the pill, then it's not post-pill PCOS. It could be something else. In that case, we need to move on to the next level, number 3, inflammatory PCOS. This one is governed by inflammation and like maybe environmental toxins, too much stress. This is really driving those adrenals to make more androgens and your ovaries to make more androgens. And then we're getting those PCOS symptoms. Now, if you say, I have like headaches, and maybe you have skin conditions, acne, psoriasis, eczema, maybe you have body aches, you have food intolerances, IBS, that could be inflammatory PCOS if you're showing those signs of PCOS along with it. And if you tell me that you don't have any of those symptoms, then we move on to the bottom one, adrenal PCOS. And this one occurs because your adrenals are pumping out too many androgens. So when you get your androgen blood work, your testosterone and your other androgens are going to be normal, but your DHEAS is going to be high. And that's a key note to decide whether or not we have adrenal PCOS or not. And then make sure that you're checking for your prolactin and to see if you have adrenal hyperplasia, because that can also show like the same symptoms. So you want to make sure that that is kind of ruled out before we go ahead with the diagnosis of adrenal PCOS. Now, the main criteria to see if you even have PCOS before we even categorize them in those 1 to 4 categories is going to be either the Rotterdam criteria or the AE-PCOS criteria. Now, the Rotterdam one, you have to have 2 of the following 3 options: high androgens, irregular cycles, and then polycystic ovaries on an ultrasound. And that's all good and dandy because if you have most of the 2 out of the 3, you classify as PCOS. But if you have the 2 out of the 3, that would be the polycystic ovaries on ultrasound and the irregular cycles, that might not be PCOS because you have to have higher androgens to have PCOS. That's like one of like the main symptoms. So that's why we go over to the AE PCOS classification that I was talking about, where you have to have all of the following. So then we have our ovarian dysfunction and or polycystic ovaries. We have a clinical or biochemical excess of androgens. So you might see that in your blood work or like extra body hair or acne, and then also exclusion of other issues that cause high androgens. So in that case, we always see the androgen thing, and that's why I like the AE classification. Now remember that PCOS has a genetic component, but it's not like if you're born with it, you have it forever and you're born with it. It's more of like that kind of loads the gun, and like your environment, your lifestyle will actually pull the trigger. So that's why diet, supplements, lifestyle can do a lot to actually help your symptoms. And these symptoms that you commonly see are like irregular cycles again, you might be skipping periods, maybe you have heavy and long periods because you're waiting so long to actually get it. That's really building up your lining. You have more cramps, you could have breakouts, acne, especially cystic acne and like along the jawline. Maybe you've gained excess weight, you have excess body hair in different places. you're showing those high androgen symptoms, and then you can even get like mood symptoms along with that as well. Now, one thing to note is that you can't actually diagnose PCOS just by looking at an ultrasound, and that's again because we normally see that string of pearls on your ultrasound that makes us go, oh, maybe you have PCOS. And they're not really cysts. PCOS is not a cyst problem. It's more of just an immature follicle problem. So basically your follicles are developing as normal. We have one that develops and starts to mature, the rest will be suppressed. That leads to ovulation. But with PCOS, we don't really see that development, and they're really slowly maturing, and then none of them become dominant. So we just have that long line of like pearls, they call it. But the problem is with just looking at that is that we can have that due to other reasons. So if you're in a birth control pill, like the combo birth control pill, that can cause that to happen because of those immature follicles. Also, if you have hypothalamic amenorrhea, that could also cause that to happen. So that's why we really need to be doing like the blood work for like fasting, like insulin and your glucose levels, along with those androgens. So just looking at someone's ultrasound can lead to a misdiagnosis. Another reason why you might get a misdiagnosis of PCOS is because maybe you're a teenager and they did an ultrasound on your ovaries and they found that those polycystic ovaries, that can actually be very common when you're in your teenage years, because usually in your adult years, you make about like 12 follicles around. But when you're a teenager, you can make up to 25, which can kind of give a missed signal of those polycystic ovaries. At the same time, like when you're a teen, you sort of have a very mild insulin resistance just because of puberty and everything. Plus you kind of get that acne. So looking at a teenager, you can't just diagnose them with PCOS because you see acne or like slightly irregular cycles, because a teen cycle can be around 45 days and still be normal. It can take some time for that to regulate. So just be wary of that if your doctor tries to put your teen or yourself on birth control right away because they say you have PCOS. Now, if it's not regulating within like a few years of your period, or if you have really bad symptoms, then yes, go ahead and try to dig deeper into it. Again, with getting off birth control, you might have that bounce back of androgens, and this could cause that post-pill PCOS. So if you get a diagnosis of PCOS after you get off the pill and you had regular cycles prior, remember it just might take some time for that to regulate. So don't let anyone tell you that you don't have a regular cycle and you're gonna have fertility issues, because we can always work on that through diet and lifestyle. A quick note on the difference between PCOS and hypothalamic amenorrhea. They can look pretty similar, both with irregular cycles, and they both can present with polycystic ovaries sometimes. And there is differences on how we treat these. When you do blood work, try to get your LH and your FSH done on day 2 or 3 of your cycle. With PCOS, there's going to be a high LH to FSH ratio, and with the hypothalamic amenorrhea, we're going to see a low LH to high FSH ratio. So basically there's just a difference in the hormones at play, and we're going to treat these different. With PCOS, we're going to figure out which type you are, so then we can use diet, lifestyle, and supplements accordingly. With the HA, oftentimes this is due to excess stress, excess exercise, and a low-calorie diet or poor nutrition. So we really need to focus on eating enough, getting enough rest, and things like that. So that's why we're treating those different. So that's all I have for you guys today on the 4 different types of PCOS, and then different reasons why you might get misdiagnosed. If you like this video and you thought it was helpful, please like and subscribe, and I'll have more content coming to you guys soon.